looks. Sorry, this is positive. The restriction of rotation is about 30%. This side, it looks normal. So then I ask her to put her chin towards her Adam's apple and turn again. The restriction to the right increases. Restriction to the left remains normal. So the motion to the left remains normal. Then I ask her to poke her chin out. Now the rotation appears normal, normal. So we have been able to increase the restriction of rotation to the right by going into flexion. Which condyle is blocking?
Right.
The right condyle cannot flex. So I'm going to take Hallie towards me. Flex to first, rotate to the barrier, relax for me. I'm going to fix the occiput and push her C1 transverse process forwards on the right. If that's not clear whether that is a hard infill, same point of restriction but on the left. What does that infill feel like? Much softer. So we've confirmed that that is a right restriction into flexion. Similarly, we can come to the conclusion it's an extension. Poke her chin forwards. Rotates to the right and the restriction increases. Movement to the left is fine. We get her to flex, rotation looks normal. So it worsens with extension, right rotation. Which joint is restricted?
Left.
The left AO joint cannot extend. We're going to go confirm that by fixing C1, take her chin into extension, fixing C1, trying to pull the occiput forwards. So here's another reason why we've got to be fluent with osteokinetics, arthrokinetics. The first test is actually an osteokinetic test. I'm moving C1 forwards under a fixed occiput. Now that's not the movement in terms of description. When I push C1 forwards under a fixed occiput, I'm testing posterior glide of the occiput. With the second test, that's arthrokinetic. I'm testing the anterior glide and I'm actually producing the anterior glide of the occiput. The reason we switch, comfort. The only way you can go into flexion, fix C1 and push that condyle back is if your finger is in their mouth pushing into the back of their throat. A little bit more comfortable pushing C1 forwards, wouldn't you say? So that's comfort more than true biomechanics. In the next scenario, the restriction to the right rotation doesn't change with flexion or extension. And I have two choices. What are they? And tell me what's actually got to happen.
Lateral's got to go downward and forward.
So the contralateral joint can't go downwards and forwards, or
Ipsilateral can go down and back.
Backwards and downwards.
you said the contralateral again.
Oh, I said ipsilateral. It goes
Okay.
forward and downwards.
Does it?
Wait, no. Oh, opposite. Sorry. Opposite, sorry.
Yeah.
Back-
In the ipsilateral
yeah,
joint,
yeah, I see what you
C2 can't go upwards and forwards. Otherwise, how are you going to get C1 going down and backwards? It could be an awfully awkward movement to do because it doesn't happen in real life. Let's turn the chair around so we see. So at the point of restriction, I'm going to fix the occiput in C1. I'm going to take C2 and I'm going to push it upwards and forwards towards her teeth. And you can see there's movement there because it's not restricted. If you want to test the enfields, just take her into slight rotation, a lot of motion. Now take her in towards the end of rotation, hardly anything. So that's what you're going to look for, is that kind of hard enfield, so that can help you distinguish between normal and abnormal. Or with the same hand hold exactly, I'm going to fix C2 and pull C1 down and backwards by shifting the weight of her head.
Down back.
Down and forwards. Just checking to see if you're following me. So I'm pushing down and forwards on the left on the contralateral joint. Is that what you learned at level 2? Is that a review or is this new stuff? I mean, apart from the biomechanics.
We didn't learn the side thing.
Okay, right. But now you can see how this is just the assessment and it's following exactly what we learned in the biomechanical theory. So you're assessing them, it will keep reinforcing what's actually happening in the joint. Because if you find a contralateral restriction, how are you going to treat it?
Same way you tested it.
Hmm?
Same way you confirmed it.
Basically the same way I found it. I'm going to take C1 down and forwards. Whether I do that as a mobilization, I can do it in sitting, stronger technique, I can do it in supine, or I can manipulate it. But in every instance, I'm thinking C1 down and forwards, because it's what happens. And when you do that, you suddenly take a manipulation which is extremely violent, because that's exactly the same way they do. Take all of the neck out by locking it up into side bending, get to the barrier of rotation, and then thrust into rotation. That is still taught in virtually every manipulative institute. But we're going to say, no, we don't need to do that, because although it's osteokinetic rotation of the head, you're going to finish that sentence? No? You're not going to take that challenge yet? It is arthrokinetically created by a contralateral anterior-inferior movement of C1 and an ipsilateral anterior-superior movement of C2. So they're two glides. They create the rotation, but they're glides. We'll focus on those, and that's what we'll manipulate. Because it's normal, this is what happens. The artery is at minimal risk. I say minimal because you never know what you're going to find in people. Okay? Here's the puzzle. Patient comes in with a gross loss of rotation to the right. You do flexion and extension. And what you notice is that the loss of movement when we use flexion increases. But when we use extension, it's the same as neutral.
So there are two joints that are restricted. So there's more than one joint that's restricted.
Okay? More than one joint? Could we have some precision?
Nope.
So in other words, the AA and the AO complexes,
Sure.
we call them that, are involved here. What's the AO joint doing? What can't it do?
Right can extend. Right condyle can extend. So you can't right.
The right can't go back.
If you can't rotate right, it can't be the right condyle, can it?
You can't rotate right.
Is it worse
It's
You said it was
inflection.
worse inflection?
Then it would
Yeah.
be the right.
Yeah. It's going to affect flexion. If it's right rotation, it'll be flexion on the right. Okay, we can't
Right.
flex on the right.
Right.
And the AA joint?
The A joint. Rotating right.
Come on, let's have some interaction.
We have to do the glides.
I wanted a more immediate response.
We have to do the glides.
Hmm?
We have to do the glides to find out.
Yes, we don't know which joint
Right.
it is. We have to then do the glides. Good. I think we're getting there. Let's practice this simple approach. Look at range of motion. We have a gross loss of rotation. Take it from there as to how you would segregate AA from AO. Okay? Practice.